So just a quick mention of the critical congenital heart disease screen. It's also called the oxygen saturation screen. It's one of the recent developments, about 10 to 15 years. It has been rising a lot, and almost 5 years when it became mandatory in most of the countries. It's very easy to do because everyone has a pulse oximeter. The only cost is that of the nursing time, and clear documentation and having a system to record it is very important. So you can say this has been in evolution for 15 years and is well established for 5 to 7 years now. And you perform close to 24 hours of age and earlier if the discharging is happening early. But in that case, bring them to the clinic earlier, and you may need to repeat it again during the clinic visit as well. You do it typically in the right hand, which is the pre-ductal blood flow. You know that the ductus arteriosus joins just before the left subclavian, and so the blood flow before that is pre-ductal and the blood flow after that is post-ductal. So the left upper limb may or may not be pre-ductal, so we usually consider it as post-ductal. And then you look at either foot for post-ductal. Baby should be awake but not struggling and have regular breathing. We record the saturation for at least 2 minutes, and we should remember that it's only to pick up the critical heart disease. It doesn't pick up a left to right shunt like a VSD, ASD, PDA, for example. So the saturation is not going to drop in those babies, and even the shunt becomes more only over the first few weeks as the pulmonary flow changes or reduces, the resistance reduces. So we have conditions like hypoplastic left heart, tricuspid or pulmonary atresia, tetralogy of Fallot, transposition of great arteries, TAPVC, and of course the severe coarctation would have borderline saturation in these cases. One of the additional benefits of doing this is sometimes you have suboptimal lung adaptation, and even though the baby is not clinically distressed, you may pick up the problem by using this system, and it may just mean that the baby needs a little more time to transition, and it is safer than when the baby is in the NICU. So it not only picks up heart disease, it also helps us diagnose other concerns. About 20% additional diagnosis can be picked up. This is just a chart to illustrate the same point. So the criteria for pass or fail, if it is less than 90% in either of the limbs, it's a definite fail. So you would need to refer on. What you do after you fail depends on your setup. So you may call the cardiologist directly, or if the neonatologist does a screening echo and involves a cardiologist when they're available, that's fine as well. But baby would need careful evaluation. You would normally do a chest X-ray as well in these babies. When the saturation is between 90 to 95% and there is a more than 3% difference, you repeat the screen in 1 hour. And if it fails again, you can repeat one more time. If it fails again, then it's considered a positive screen. And if it is more than 95% and the difference between the pre and post-ductal is less than 3%, then it's a pass and you don't need to do anything more. Of course, it doesn't mean that you don't consider any concerns. If the baby deteriorates, the baby passing the initial screen doesn't rule out problems, and you still have to start with bigger in a symptomatic baby.